Welcome everyone to today's program. I'm Tamara Rosen, Assistant Editor for Becker's Hospital Review. The program will begin with a presentation and we will have a question and answer session following completion of the program. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as she can during this time. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Kelly Morrison leads the nation's largest remote pharmacy services business and helped pioneer the remote medication order processing service for Cardinal Health. In 2003, she submitted a patent for the proprietary technology that later became commercialized and used by over 450 hospitals today. For the past 13 years, she has worked to provide remote pharmacy services to over 400 healthcare facilities. She is a co-author on the ASHP guidelines on remote medication order processing and presents this topic at professional meetings on a national platform. It is now my pleasure to turn the floor over to Kelly to begin today's presentation.
Thank you, Tamara, and welcome and good afternoon, everyone. I want to thank everyone in advance for joining today's call and really just jump into it. So our objectives today for this session are really to go through identifying healthcare reform's impact on pharmacy and how that's presenting some additional challenges for larger healthcare systems and academic medical centers in the marketplace today. And then we're going to really talk about considerations when evaluating when a remote pharmacy model may be applicable to address some of those challenges that you may be facing. From there, we're going to really transition into some overview slides highlighting what some of, more than likely, your peer hospitals have done and how they've leveraged various remote pharmacy models to address some of the challenges that they're facing and really provide some unique labor solutions that were very cost-effective yet ensured a very high level of quality. We're going to then highlight some unexpected benefits when these facilities leverage remote pharmacy services and really explain to you and gain an understanding how to really maximize those benefits if your facility chose to leverage remote pharmacy services in the future. So with that, we know that healthcare reform is presenting many, many challenges for our healthcare facilities out there today. Doing more with less has become standard practice for hospital pharmacists in particular. There's an increased need for pharmacy-led clinical programs to drive hospital cost savings initiatives, reduce readmission rates, and increase patient satisfaction. And we also know, and all of you can attest to this, that personnel and project budgets are flat despite growing hospital administration expectations. Many new focus areas are bringing many new pressures to the forefront. Examples of that are medication reconciliation. We see that really as the forefront of many additional pharmacy-led clinical initiatives. In 2012, a systemic review found evidence that pharmacist-led processes could prevent medication discrepancies and potential ADEs after discharge, and that implementation of clinical programs and new technologies definitely decrease adverse drug events and costs for the hospital. So again, this really goes back to the fact that we've known for many years the importance of the pharmacist being involved at the forefront through the entire medication use process. But over time, and as the Affordable Care Act has been implemented and deployed, pharmacies are now being pulled into many other directions and many other areas that they weren't pulled into prior to such changes. When we're looking at how one can leverage remote pharmacy services as a unique labor alternative to supplementing on-site staff, there's many different ways in which we've actually seen that be accomplished. One is if your hospital is looking to expand their pharmacy services, and I don't know of any hospital out there that's not facing this challenge today, whether it's presenting med reconciliation programs, and med reconciliation can be done, it's defined many different ways. It can be defined upon patient being admitted to the hospital, as well as pre-discharge and wanting to reconcile this medication prior to discharge and provide patient counseling prior to them going home and leaving your facility. We're seeing pharmacies being pulled into transition of care programs, being asked to implement new programs, meds to beds programs, for example, by which patients are provided their discharge meds prior to even being discharged from the hospital themselves. Again, going back to trying really to ensure a high level of compliance to the care programs that they're provided. And then we also see an expanded pharmacy support in the emergency department and procedural areas. And these are areas that prior to a lot of the new technologies that are being developed and implemented, pharmacy didn't have a heavy involvement. But post-computerized physician order entry in particular, we're seeing that pharmacies being asked to get more involved in those areas. And while oftentimes we'll see that pharmacies will configure systems to where a lot of the orders, medication orders that are entered by physicians electronically are set to auto-verify, in some cases that's probably not the safest practice, and therefore again increasing the need for that pharmacist presence and prospective review of those orders in addition to orders being written throughout other areas in the hospital. We're also seeing a real need to redeploy on-site pharmacists from order entry responsibilities to focus on strategic projects and clinical initiatives. We're seeing pharmacists being pulled from the pharmacy and doing the day-to-day order entry work to working more directly with the physicians and being a strategic part of the care teams themselves, having a lot more involvement and face-to-face involvement with the patients. We also can leverage in looking at remote pharmacy services to supplement short-term project work to meet meaningful use requirements. So again, whether you're redeploying pharmacists permanently, again, to focus on other initiatives, or even needing to have a temporary, shortage of pharmacists because of short-term project work as you're implementing technologies. Again, these are different ways in which we've seen hospitals look to leveraging a remote model as something that could actually allow them to achieve their goals. We also look at when a healthcare facility needs to provide workload balancing and reduce order review and order entry times, especially during peak hours. A lot of the larger healthcare facilities already have pharmacy services 24 hours a day. But as they're being asked to do more, we really want to look at how they can better balance the workload, again, to ensure a consistent level of care 24/7. And we're also seeing how remote pharmacy services can be leveraged to provide nursing and technician supervision remotely. And while this may not be as needed at some of the larger academic medical centers and healthcare systems, it becomes more critical and essential at some of your smaller affiliate hospitals that may be in isolated or rural areas. So the next couple of slides, what I'd really like to focus on, and the bulk of the presentation today, is how we've seen customers leverage remote pharmacy services in various different models. Traditionally, remote pharmacy services has been leveraged to really help those smaller to mid-sized community hospitals that lack 24-hour pharmacy coverage. And this has really been the traditional approach for remote pharmacy services for many, many years. It enables those hospitals that lack 24-hour pharmacy coverage a way to ensure that a pharmacist clinically reviews all non-emergent medication orders prior to being administered to the patient. But over the last couple of years, and really talking to a lot of the larger healthcare systems that, again, traditionally would not have any need for supplemental remote help, they now find that they've got some challenges where remote supplemental help may be just what they actually do need. And so as we go through some of these overviews of customer challenges here over the next few minutes in this presentation, we really want to highlight, number one, who the customer is, number two, what their challenge was, and then again, so what was the approach? What approach did that customer determine to take to address the challenge? And then what were some of the results? Because as with any situation or obstacle, there's many different approaches one can take, and so I think it's very helpful for everyone to understand the evaluation and considerations each of the customers in these examples took and how they got to where they were in the determined approach. So the first hospital that we're going to talk about today is University of California, San Francisco, a 600-bed medical center in Northern California. They were looking to implement computerized physician order entry. Of course, they have 24/7 pharmacy services. And the challenge was, how are they going to provide a consistent level of pharmacy services during this technology adoption? It was a several-month adoption. They knew that pharmacists were going to be pulled for training and helping to actually build and configure this system. And they knew they were going to need more pharmacists during this period, not only prior to implementing the new computerized physician order entry system, but perhaps even post, not really sure of the challenges they may face once they migrated to a new technology. So what this hospital decided to do is look at, they felt like they didn't really need supplemental help long term, and so they just wanted a short-term project. And by short-term, they were looking at probably about 6 months, just 6 months worth of assistance to help strictly with providing labor assistance during the CPOE implementation. They certainly didn't want to hire additional FTEs because, again, they didn't anticipate needing more FTEs once CPOE was implemented, just how were they going to address the pharmacist shortage while it was being implemented? Because at any given point in time during the CPOE implementations in particular, pharmacists are expected to train about 55 to 75 hours. And that doesn't count the time it takes then for them to actually play in the test system, if you will, to prepare for the migration. So for a lot of these hospitals, at any point in time, they're actually down about 30% of their workforce as they prepare for some of these technology implementations. And this customer was no exception. So what they did is they knew they weren't going to hire FTEs, and they looked at the volume, of workload that needed to be handled while about 30% of their workforce was out. And so looking to bring an agency they felt like probably wasn't the best solution, not to mention some of the agency personnel lacked the knowledge of the system, not only their existing system, but the system they were converting to. So they felt like looking at a remote pharmacy service provider was probably the best fit for their particular challenge, and that's what they did. And so what they decided to do in collaborating with a remote service provider is engage 90 days prior to their computerized physician order entry implementation, so that as their pharmacists were being pulled to build and train on the new system, the remote team could supplement the on-site team 24 hours a day, again, to ensure they had adequate pharmacist review of the medication orders that were being written. Then for the implementation, there were several thousand orders that needed to be entered from the old system into the new system within a 24-hour period, not to mention keeping up with all the new orders that the physicians were continuing to prescribe even while the conversion was happening. And so again, they felt like leveraging this remote team, and what the remote team was able to do during that time period was scale up and more than double the staff that they had in place prior to the conversion, just to help during that 24-hour period to get the hospital really over that spike of order volume and being onto the new system. Post-implementation, the hospital decided to go ahead and keep on remote services to supplement their team for another 90 days. And they did this because, as with any new technology, there's often learning curves, and especially if your staff has been on the same system for many, many years, as we see much of the time. And so rather than try to overtax their staff with not only learning a new system but continuing to keep up with what they were expected to do before, they went ahead and kept the remote team online again for another 90 days. And there's several reasons to do this. And one of the things that this hospital found, and many hospitals that we talk to and work with also have found, is that post-computerized physician order entry in particular, the amount of order volume that the pharmacy is processing typically can increase up to as much as 30%. And in some cases, we've seen even more. And there's several reasons for that. One of the primary reasons is just because post-CPOE, as we talked about a little bit earlier, pharmacies are now expected to provide order review and approval for areas that they didn't or weren't involved with prior to that CPOE implementation, like the emergency department and procedural areas. So that alone creates a spike in order volume. In addition to the way CPOE systems are handled for sliding scale and range orders, for example, that can result in pharmacists having to enter more orders than they had to previously. So post-CPOE, oftentimes, actual just sheer volume itself goes up, even once the pharmacists are comfortable with the system. Now we'll move on to another example that's similar to our UCSF example, but has a couple of different nuances. This example is Brigham and Women's Hospital and Mass General in Boston, Massachusetts. Brigham and Women's is a 793-bed facility, and Mass General, their flagship hospital, is a 900-bed teaching hospital. Again, both already have 24-hour pharmacy coverage, but they knew they were planning to convert to CPOE with Epic, and they knew they needed additional pharmacy support because they anticipated increased workload just based on some additional evolving pharmacy initiatives that were to be implemented post-CPOE. Now in this case, I mentioned one thing because as you look to work with a remote provider, and when I say remote provider, and you'll hear me mention that continually through this presentation today, that could be a third-party service provider. It could be a sister hospital. It could be a local community hospital that you work with to try to, look at how you can allocate staff amongst one another and provide kind of workload balancing. But whatever the model is that you choose to implement, one of the things that we looked at in talking to this hospital is that we tried to implement a program that would be very simplistic so that as any of the hospitals in this system were converting to Epic or any new technologies, they could leverage a remote model really, really, really quickly. And so again, when you look at just terms of agreements with providers, trying to simplify those as much as possible is very key, because oftentimes you may not anticipate the need at one particular hospital in your system and not have a lot of lead time once you do recognize that need. So again, that was done with these particular hospitals, and we really looked at a multi-phase solution to help aid them in the Epic conversion. Now, unlike the first hospital that we talked about, this hospital chose to not leverage remote pharmacy services prior to their CPOE conversion to Epic. And they made this decision simply because the pharmacy information system that they leveraged prior to the conversion was a proprietary system that had a lot of nuances and complexities, and they felt that as they looked at their investment in bringing on supplemental pharmacist help, that it would be much better spent post-conversion than prior conversion. So what these two hospitals did is they brought the remote staff on simply for the cutover, so literally day one when they were having to enter all the orders from the old system into the new, and then kept the remote pharmacy team on for several months post-conversion, again, just like UCSF did, to really help smooth things out while the on-site pharmacy team were going through the learning curves. A couple of other unique nuances about these two particular hospitals is that on the day of the conversion, the remote pharmacist actually worked on site as opposed to being remotely. And this is something that these two hospitals found very helpful. Because their cutover and the volume of orders that needed to be processed was so significant, there was kind of a core team, if you will, on site at each hospital on cutover day, supplemented by remote teams, so that as questions arose, clinical interventions came up, etc., they could be handled most efficiently. Now, the on-site pharmacists that were traditionally remote, they only worked on site for the day of the cutover, and after the initial 24 hours, went back to working remote. And for that cutover period, about 40% of the actual workforce came from that remote supplemental team. Post the CPOE conversion to Epic, basically initially the hospital prepared for a 4-month commitment by which the remote team would process about 27,000 lines a month. Again, just looking at certain areas that they wanted the remote team to handle while their on-site team could focus on other areas in the hospital, again, while they continued to learn the new system. Their learning curve, again, as they went on month by month, they continued to evaluate it. They continued to evaluate the order volume increases that they experienced post-cutover. And in total, it resulted in about 11-month commitment that they needed these supplemental resources. And I mention this because for those of you on the call today, as you are approaching, or if you are approaching a CPOE conversion or implementing med reconciliation technologies, etc., it's just always good to know up front that once you get to the cutover, that may or may not be good enough for supplemental help. And again, supplemental meaning whichever model you choose to implement. And it's really good to work with, whether it's, again, a sister hospital, whomever's providing the additional coverage for you. You've got to have a close relationship, and we'll talk more about this toward the end of the presentation, and continue to evaluate the length of time that you're going to need that supplemental support. Because when you go into the project, you can make assumptions, but then when you come out of it, some things can cause those assumptions to change. And so just being very open to that and aware of that, I think, is really critical and key. Now, another healthcare system, and this is Scripps Healthcare System in Southern California, they had a bit of a different need for additional labor. They were looking to meet stage 2 meaningful use requirements around medication reconciliation, and were building out a patient portal. And for 6 months, they needed all discharged patient orders entered into this portal manually as they built the technology that would ultimately do that automatically upon a patient's discharge. Now, this healthcare system actually has an internal remote order entry service, if you will, that currently and already provides supplemental help to the hospitals within this system. And so, of course, when this challenge arose, they evaluated all different options. They looked at, can we bring in outside help from an agency perspective? Can we leverage our internal remote order entry service? They couldn't leverage any of their existing hospitals to help one another because they already were overtaxed and being helped by, again, their internal remote service as it was. And when they really evaluated and looked at the number of discharge scripts that actually needed to be entered and the time frame in which that needed to be completed, they realized they really needed additional help. They did not want to overtax a team that already was what they felt like probably over capacity. So they felt like in this case, leveraging a remote supplemental team was also key and very cost effective in enabling them to reach their goal. And so they did. They contracted with a remote pharmacy service team to supplement their staff and support the entry of the discharge orders. And in fact, were able to meet the deadline in 5 months instead of 6. And when they looked at just the labor savings alone by leveraging a remote team as opposed to hiring additional or looking at agency personnel, they saved almost $420,000 in labor. Again, and that was just over a 5-month period. And in that 5-month period, just under 100,000 orders were processed by that supplemental team. So the real advantage and what this hospital actually found rewarding is that they not only rose to the challenge, they came in under the time frame that they were expected to, yet at the same time, hospital pharmacists were able to provide a continuum, consistent level of patient care. In fact, the nurses and the physicians and everyone around them, they weren't even aware of what was going on behind the scenes. So this remote team was able to go ahead and enable them to meet their goals without any disruption to their current operation. Another example of how a customer actually looked to leverage a remote pharmacy service model was by looking to reallocate pharmacists to focus on clinical work. Now, this is a 17-hospital healthcare system across 7 states, IASIS health system, and their challenge was they really needed to deploy current pharmacists to clinical initiatives. They wanted to get their clinical pharmacists out on the floors working directly with the physicians, and they wanted to do this without hiring additional staff because they didn't need a full FTE necessarily at each of their hospitals to do this. They were challenged with how do we accomplish this? And in fact, at some of their hospitals, it wasn't that they were small hospitals, but they were rural in more isolated areas. And even if they felt like hiring FTEs could potentially be a solution, they were challenged finding FTEs in this case to be able to do the work. So what they looked at and ultimately implemented was what we like to refer to as more of a blended staffing model, which is really just a hybrid of on-site pharmacists working in tandem with a remote pharmacy team. They utilized the remote pharmacy team for the day shift so that they could free up the clinical pharmacists that work during the day, again, to work directly with the physicians and caregivers out on the floors. When they did this, they transferred the majority of all the order volume during the day to the remote pharmacy team. The pharmacists were then, their pharmacists on site, were then finally able to attend daily case management and ICU rounds, which they found incredibly beneficial. And some results just from one of their smaller hospitals that decided to leverage this solution was that they were able to decrease their antibiotic cost per adjusted patient day. In a 12-month period, they decreased the cost just over 11%. They found their clinical interventions increased by 150%. So as a result, they were able to decrease preventable adverse drug events because now the pharmacists, these clinical pharmacists, were actually on the floors focusing really with the physicians as they were prescribing the medications. For one of their smaller hospitals, they saw an antibiotic savings just under $90,000 in 12 months. It increased their productivity, and they were able to save about $55,000. And from an increased productivity perspective, what that looks like is they looked at what would it have taken if they would have brought in an FTE and or agency staff as opposed to bringing in a remote pharmacy staff and what the costs of that team were. So again, this healthcare system looked at things a little bit differently. They had a different type of challenge, but in the end, leveraging a remote model actually was what worked best for them and enabled them to meet their goals. Another customer that we want to highlight is a 6-hospital IDN in Tulsa, Oklahoma, Ardent Health System. And they had yet a different challenge. Within this healthcare system, they had a flagship hospital that had 24-hour pharmacy services, more of a mid-sized hospital that also had 24-hour services, and the mid-sized hospital was staffing 3 of their smaller rural sister facilities. They really needed to contain labor costs, yet additional staff were needed at the flagship hospital just to handle the order volume that they were seeing. And so they had a choice. They could have hired more pharmacist FTEs at the larger hospital to handle that volume, but when they looked across their entire system and really what the order volume was aligned to the pharmacist, capacity that existed, they found that if they could just shift the on-site pharmacist at the mid-sized hospital over to the flagship hospital, redeploy them there, that they could maybe look at actually closing the night shift pharmacy at the mid-sized hospital and instead leveraging a remote pharmacy team to handle the order volume that was coming through not only for the mid-sized hospital, but also for those 3 small sister hospitals that were being serviced previously. Now, this hospital looked at something creatively because one of the things that is a consideration in each of your states, of course, as you know, as you look at any type of labor model, is licensure requirements. And the state of Oklahoma has something that is a bit unique to some of the other states in that in Oklahoma, you can't leverage remote pharmacy services to supplement on-site team if on-site staff is actually there. And so that's part of what drove the decision to redeploy the night staff at the mid-sized hospital over to the flagship hospital, because they couldn't have leveraged remote services just to supplement, at either one of those. And so that's exactly what they did. And when they looked at what the labor savings were compared to if they would have tried to hire FTEs themselves to accomplish this, because again, this wasn't short-term, they needed a long-term solution, they actually found they saved just under about $240,000 annually in labor savings, and that's labor savings for the flagship hospital and labor savings for the rural hospitals that were being serviced remotely by the remote team. And then in addition, when you look at the clinical and the operational impact, when you look at the annual estimated order volume that the remote team was handling, it was about 141,000 orders. And the interventions that were actually performed by the remote pharmacist were just under 3,000. So when you look at the annual estimated preventable adverse drug event savings, that came out also to a little over $300,000. So again, this hospital saw a real value in leveraging remote pharmacy services, but again, for a different reason and a bit of a different way. Now, the CEO of these hospitals has actually spoke about this because there were many challenges up front, especially when you think about redeploying pharmacists from one hospital to another, and some of the considerations that need to be taken into account prior to doing that. And we're going to talk about some of those considerations that not only this hospital had to really evaluate, but that each of the health systems that we've mentioned today had to evaluate as they look to leveraging remote pharmacy services as a potential solution to their challenges. Now, when we look at just some of the benefits that these health systems saw to remote pharmacy models and leveraging a remote pharmacy model, these aren't isolated. We talk to hospitals all over the country and really try to better understand what their challenges are, because again, as you know better than anyone, your challenges continue to evolve and continue to change. And the challenges that we all face within the healthcare environment 5 years ago are vastly different today than they were then. But some benefits that, just to educate everyone on the call to be aware of, or that you should expect when you leverage your remote model, and again, whether the remote model is using a service provider, an internal type service, or a sister hospital, etc., are really threefold. And they fall into operational, financial, and even cultural. And cultural sometimes surprises people. From an operational perspective, really those benefits seem to be fairly obvious. Of course, it will enable the on-site pharmacy's full commitment without distractions if they're engaging in training and implementation of a new system. And also, it can ensure pharmacy service levels are consistent when pharmacists are pulled away temporarily or redeployed to clinical initiatives. From a financial perspective, it can eliminate the costs associated with recruiting, training, and even benefits and burden of bringing on FTEs, whether it's short-term or long-term, and definitely helps reduce preventable adverse drug events and the costs associated with the mitigation of them. From a cultural perspective, though, in talking to a lot of pharmacy leaders out there that have looked at trying to leverage and have successfully leveraged a remote pharmacy model to supplement their on-site teams, it really enables the pharmacy to scale their staff as needed without impacting FTE personnel. For some of these large healthcare systems that really feel like they need the supplemental help, but on a short-term basis, and by short-term, that could be 3 months, that could be 12 months. They really didn't want to look at bringing in full-time pharmacists only to know that after the 3 to 6 to 12 months, they wouldn't be needed anymore and that they would be severed. And so therefore, looking at a remote pharmacy model really enabled these systems to actually scale up and scale down very efficiently, real time, as the volume and the need dictated it. And also from a cultural perspective, by leveraging remote pharmacy services, it really can help demonstrate hospital leadership's commitment to work-life balance and job satisfaction. All of our pharmacists already feel very overworked and overtaxed, and this is before now they're being asked for pharmacy to be leading other programs and strategic initiatives in the hospital. And as technologies are implemented or new initiatives are implemented, it's very, very difficult for pharmacists to do more than they're already doing today. So by leadership looking at what are some creative models that we can do to actually assist that on-site personnel, we've really seen a benefit, and these health systems have seen a benefit to job satisfaction for these on-site pharmacy teams. Now, when we look at how to maximize the benefit of remote models, so we've talked about how and perhaps when to leverage a remote model based on certain challenges that we've seen other health systems have in the marketplace today. There's really some considerations that you need to take into account in order to maximize those benefits, because just like any type of model, if implemented incorrectly or inefficiently, you often don't realize the true benefits that you were expected or the return that you were expected. And so one key thing to always think about is be active on the front end. Align the provider's capabilities to your specific needs. And by provider, again, that may be a third-party company that provides remote order entry. It could be a sister hospital that has additional staff. Wherever the labor is coming from, especially if it's in a remote nature, you always want to do a thorough evaluation. Look at multiple different sources of labor. Really do your due diligence to determine which source of labor and from where would best meet your needs. If you've got large volume, for example, and you need scale, that's going to probably come from a different labor source than if you don't need as much scale, and if the volume that you need help with is a lot smaller. In a lot of these health systems that we talked about today, they actually did time and volume analysis ahead of time so that they could really determine how to best position the supplemental staff that was used remotely, again, to help them achieve their goals. Also, you want to be really aware of whatever team that you look at to provide this additional labor, and particularly in remote teams, is licensure. A lot of systems that we come in contact with are nationally based, and therefore having licensure in one state isn't adequate. And so again, that goes back to aligning the provider's capabilities or the source of the labor's capabilities to what your specific needs are. And finally, I would also mention that just a very in-depth knowledge of the system that you currently have in place today is also critical, because that will really enable the remote provider to, from day one, be highly effective and successful in helping your on-site team. If you're going through a technology conversion, it's additionally important that that remote team be very familiar with not only what your current system is, but also the new system that you're going to. It's also important in maximizing benefits to engage the frontline teams in the evaluation and implementation. Letting pharmacy know that they've got a say in the on-site staff in how we're going to implement this and how best to implement it, I think, is really key. In almost each of these situations, the frontline teams were engaged in evaluating capabilities of the remote pharmacy provider to determine how do we best work side by side. In some cases, it may be assigning the remote pharmacy team specific units. In other cases, it was assigning the remote pharmacy team specific orders. But it's incredibly, incredibly important to get feedback and input from those frontline teams. For example, how are clinical interventions going to be handled? How are discussions with physicians, nurses, or caregivers going to be handled? And in each of these cases, how the processes put together to handle those were somewhat different and unique to each specific facility. Another key area that's incredibly, incredibly critical, and I cannot stress this enough, is when you engage a remote pharmacy team to actually supplement your on-site pharmacy team, you can't view this as a traditional vendor model and as if it's one other vendor that you're tacking on to provide services. It's critical that you view remote pharmacy as a partnership model with two-sided communication, as I mentioned here, and joint accountability. The team should be seamless. The interaction between the team should be seamless. And really, the remote team should be just a natural extension of the on-site team. They're very well equipped typically to do just about anything the on-site team does outside of dispensing and daily tasks that would require someone to be on-site. So again, as you look to some of the challenges that you face today, and some of them may be very similar to some that we've talked about during this discussion, and you want to look at exploring the idea of how maybe a remote pharmacy team could help you address some of your challenges, really try to look at some of these considerations that we talk about if you choose to go down the path of implementing remote pharmacies. Now with that, what I really want to do is kind of bring it all together and talk about, just so you can think about the role of remote pharmacy services, or what the role really can be. You know, we talked earlier about some of the challenges that healthcare systems are facing today in light of healthcare reform, and that pharmacy teams now more than ever are being pulled in many different directions and are being asked to lead many more strategic initiatives that in the past maybe was not the case. They're asked to have reach in areas that maybe they didn't have reach in before. And so as you look to that, again, you can leverage remote pharmacy services to really help expand the pharmacist's reach and transitions of care. We're seeing this more and more, as I mentioned earlier in the discussion, where inpatient and outpatient pharmacies are working closer together than ever. Again, whether it's through meds-to-beds programs, whether it's patient discharge counseling, or even post-discharge from a medication therapy management perspective. Again, we all see the pharmacist's role expanding, but there's only so many, and there's so many that you have employed today. And so as you want to take advantage of some of these additional programs and additional initiatives that require the expertise of the pharmacist, leveraging remote pharmacy services is a great alternative to be able to enable you to do some of those. You can also leverage remote pharmacy services to support the improvement of clinical outcomes. And by this, we really mean that, again, at the end of the day, the goal is to ensure that clinical review of those medication orders prior to being administered to the patient. And so no matter what the project is, or no matter what the initiative is, really balancing the amount of pharmacist labor to the demands that are coming in. Because if there's more demands than you have labor and time, then something's going to suffer, unfortunately. And so as long as you've got adequate support, then we've definitely seen an improvement in clinical outcomes. We've talked about that earlier on in the presentation, that pharmacists being involved, there's a direct correlation to a reduction in preventable adverse drug events. Increasing pharmacy and hospital access to patients. And again, this just goes back to how do we expand the pharmacist's reach, again, with limited resources, and a great way to do that is by supplementing them, leveraging a remote model. Leverage the on-site resources for what they are best in doing, and get them in front of the caregivers and get them in front of the patients, working more directly. And you can enable the remote pharmacy services team to do what's typically done in the pharmacy itself. And again, we've seen remote pharmacy services enable hospitals to reduce healthcare costs and increase efficiencies. Again, the fewer preventable adverse drug events that we have, and the amount of time and cost associated with those can definitely be reduced as long as you've got that prospective pharmacist review of those medication orders, again, prior to being administered to the patients. And it definitely increases the efficiencies of the on-site pharmacists. They now are freed up to focus on whatever specific initiatives that you've deemed are more valuable for them to focus on. And they're not trying to split their time between order entry and focusing on some of these other strategies that may be put in place to improve quality or even drive down drug costs. So with that, as we think about looking to the future, there's a strong focus on telehealth. And this goes beyond remote pharmacy services. Remote healthcare services are becoming more and more commonplace. While some of the large health systems and academic medical centers have large clinical teams and probably leverage a lot of on-site labor, many of you out there have many smaller affiliates that are in isolated or rural areas. And so there's really a goal to ensure access to healthcare services in some of these isolated and underserved geographic areas. And leveraging a telehealth model by delivering healthcare remotely is becoming more and more commonplace. Technology is really catching up, and there's many technologies that are very efficient and becoming more and more cost-effective that can really enable the effective deployment of telehealth models out there in our healthcare space today. And ultimately, we really want to look at promoting a patient-centered healthcare system. And the best way to do that is looking at telehealth models. How can you expand the clinical reach, whether it's through of an intensivist, of an ED physician, of a nurse, or a pharmacist? How do you expand that reach into some of these areas? And what we've seen is one of the best ways to do that is through some form of a telehealth model. And again, the technologies exist out there today where once they did not, and those created some hurdles and challenges. But today, a lot of those have been overcome. And so as we look to the future, I know today we focused primarily on remote pharmacy services, but please be aware and be prepared for it, and even get ahead of it as you can, that remote services are going far beyond just the pharmacy. So with that, I'd like to turn it back over to Tamara and see if there's any questions.
Thank you, Kelly, for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Kelly will attempt to answer as many questions as she can during the time we have for Q&A. The first question we have here from an audience member, he wrote, "We are interested in remote pharmacy. Is it common for a remote pharmacy company to also manage the pharmacy and provide oversight with an on-site pharmacist or manager? And the same goes for the development of a 340B program within the hospital."
Absolutely, and that's a great question. And we're actually seeing that more and more. Having on-site management in conjunction with remote support is commonplace now. So the applicability of that is the answer to that is absolutely yes. And the key is what we talked about earlier is align with a provider that you know can provide that on-site management and leadership in addition to managing and overseeing the remote staff in conjunction with 340B capabilities. The provider themselves can determine what's most appropriate to be handled remotely versus on-site. But absolutely, yes, that's very possible.
Thanks, Kelly. The next question we have here says, what is the typical implementation timeline to leverage remote pharmacy services?
So great question. And again, this goes back to really aligning the provider's capabilities with your specific needs. So in some of the overviews that we looked at today from some of the customers that were highlighted, the average implementation time frame was about 30 to 45 days. And again, a lot of that has to depend upon making sure that there's enough pharmacists that can handle the scale, depending upon what your challenge and your need are. And also, it's critical to make sure that the pharmacists, again, have the licensure that may be needed, as well as a good working knowledge of the technologies that you have at your facility today.
Wonderful. The next question we have here is, how do you see remote pharmacists implemented in the telehealth subacute model?
Great question. And it's interesting because over the past probably 18 months, we're really seeing remote pharmacy services move to adjacent marketplaces, such as in the community health center space, where some of these mid-sized and smaller community health centers, you know, they're not large enough to sustain several FTEs, but they really want a pharmacy to serve the population. And so we're seeing them start to leverage remote pharmacy models by which they centralize the labor pool, if you will, so that they don't have too many FTEs. They can actually make it affordable. We're also seeing remote pharmacy models being leveraged in the post-acute space through long-term care, nursing homes, mental health homes, group homes, etc. We see remote pharmacy models actually being a partner to some of the closed-door pharmacies that are providing the support to some of the non-acute or subacute spaces. So leveraging remote pharmacy in the subacute or post-acute space, if you will, is highly effective. And really the biggest difference there is the technologies can be a little bit different when you start looking at the subacute space. But other than that, we're seeing it and are very active outside of the acute space. And quite frankly, as we look to the future, we see that as probably even a bigger opportunity than the acute care hospital space because there's so many more facilities outside of acute care.
That's interesting. Thanks, Kelly. Another audience member would like to know, do you use any automated dispensing technology, or is dispensing done by on-site pharmacists?
Another great question. So the dispensing is done by the on-site pharmacist. So from a remote perspective, the remote pharmacist enters and approves the medication that is in the the hospital's pharmacy information system, and then that typically is interfaced to the automated dispensing cabinet vendor, and then the nurse, of course, on site goes and dispenses that. And this isn't exactly an answer to your question, but because you mentioned ADMs, I did want to bring up another creative use of remote pharmacy services. So we've seen some small surgical centers, well, all across the country. And depending upon the state they're in, they have varying licensure and regulatory requirements about a pharmacist's involvement in being on site and the amount of time that a pharmacist has to be on site. And so we've actually seen some of these smaller surgical centers and smaller hospitals leverage remote pharmacy services to actually verify the automation fills for those facilities, because a pharmacist, by regulation, has to verify that a technician actually retrieved the correct medications that they're going to be stocking in those automated dispensing cabinets. But what we found is you certainly don't have to have a pharmacist on site to verify that, because through some really advanced video conferencing and digital still technology, it can be done remotely and much more efficiently and effective than by having a pharmacist be there on site for just a short period of time for that purpose only.
Thanks, Kelly. Another audience member asks if you could please expound upon remote support for medication reconciliation.
Sure. So there's various scopes of medication reconciliation that we've seen today. The whole idea behind medication reconciliation, right, is number one, upon admission, making sure that all the medications that the patient has been on are identified, and then reconciling those and working with the physician on which medications do you want to continue, which medications maybe need to be discontinued based on contraindications or other issues that may arise, but based on new medications that are being prescribed. And so we've seen it several ways. One way is where hospitals will leverage remote pharmacy services to supplement their pharmacy staff while they free up a pharmacist to work in the ED or other areas of the hospital to actually perform the med reconciliation themselves. And then in other cases, video conferencing technology has actually been used to be able to, again, identify meds that are brought into the facility where the remote pharmacist is doing the reconciliation themselves. So it can go either way. More times than not, we found that it's probably more efficient if the on-site team is used to actually perform the med reconciliation and the remote team is used to backfill those pharmacists that are having to do the med reconciliation duties.
Great. Another audience member asks, we would likely use RPS for overnight medication orders. How does RPS deal with continue home medication and other incomplete orders that need to be clarified?
Great question. So what the remote or at least, and this would be a question of the remote pharmacy provider, you know what I mean, that you chose, but what should be expected is that that remote pharmacist will pick up the phone for any clarifications, working directly with the nurse and even the physician, and that remote staff, again, one thing I mentioned earlier, it's key that they are a natural extension of the on-site staff, and they should be available to your nurses and physicians after hours if there's drug information questions or, again, any clarifications that are needed. And in a post-computerized physician order entry environment, we see more clarifications than ever.
Thanks, Kelly. Here's another question from the audience. What is your approach to getting the telepharmacy services viewed as a personal service, like a local pharmacist, by the nursing or medical staff at the remote site?
I'm trying to think about how to, could you ask that question again? I'm just trying to think about how to best.
Yeah, certainly. What is your approach to getting the telepharmacy services to be viewed as a personnel service by the nursing or medical staff at the remote site?
I'm not sure if I'm going to provide the answer you're looking for, but I'm going to try. At first I thought it was personal service, and then the second time.
I know. I'm sorry. I think I misread the question at first.
That's okay. So how do you get them to view the remote pharmacy as a personnel service? Is what I'm thinking.
Like a local pharmacist? Okay. That was a no in parentheses there. I don't know if that helps.
Okay, not a problem. I think I'm going to attempt to answer it, and please ask a follow-up if I don't. And I'm not sure I'm going in the right direction, but I'll try. It's very, very critical that the nursing team does view the remote pharmacy as additional pharmacist personnel. There's many, many, many ways to do that. But probably the best way is to ensure that the remote pharmacy provider that's selected has that very personal touch and is actually treated and actually responds as if they are a member of that hospital and a member of that pharmacy team. I'm not sure that was the direction of the question that you were asking, and so I apologize if I'm not answering it directly, but again, it is very important. When you're leveraging a remote team, the goal is that nursing really isn't even aware that you're remote, other than they may have to dial a different phone number if there's a question. And again, the goal, the way to achieve that is making sure that the remote provider is following all of your protocols, all of the same policies and procedures, et cetera, so they are viewed as the equivalent to an on-site pharmacist.
Okay, thank you. Here's another audience question. How do you handle different pharmacy information systems, i.e. Meditech?
Great question, and there's so many out there. As it relates to Meditech, there's so many out there, so many versions of Meditech, and just even of itself. And so I'll speak from the Cardinal Health experience, and again, doing this for a very, very long time. We've got experience with well over 30 different pharmacy systems, and that includes all the different variations and versions that there may be. But it's incredibly important that a due diligence process is done prior to implementation, by which a pharmacist actually comes on site to your facility and documents your pharmacy information system, because Meditech's a great example that if you've seen one Meditech, you've seen one Meditech. Different hotkeys can be configured differently just to perform the same function. And so at least for Cardinal Health, I can speak to, we send a due diligence pharmacist on site. We actually have a 47-page due diligence document by which we collect information not only about your pharmacy information system, but also your specific policies and procedures. That pharmacist then goes back and trains the remote pharmacist that will be responsible for that specific facility. And so, of course, over time, just from vast tenure in the market and experience, the pharmacists have a vast array of knowledge in various systems. Another benefit that sometimes people don't expect from a remote pharmacy services team as well is the remote pharmacists have seen quite a lot, as you can imagine. And so I know one of the things that we strive to do in particular is we go on site and we evaluate your pharmacy system. If we see things that could be configured differently, we certainly will make recommendations. It doesn't mean that you necessarily want to change the way anything's configured, but if we've seen things set up from a best practices approach that can create efficiencies even for the on-site team, we certainly recommend that. We also have a vast library of training videos that we maintain and keep updated for all the pharmacy systems that are out there.
Thank you, Kelly. Here's another question from the audience. What is the maximum number of FTE staff that can be under supervision of a remote pharmacist?
That's an interesting question, and there's not a hard number out there. And so I know at least through Cardinal Health, we have 11 different teams of pharmacists across the country that work out of licensed pharmacy service centers, and they range anywhere from 3 to 5 pharmacists to there may be 12 or 15 working concurrently. But I've not seen any type of best practices number out there to be able to give a good, a good ratio of that. The pharmacists are all pretty independent, if you will, although they all work in teams that have a lead pharmacist, and they also work in teams that have a director.
Okay, thanks for clarifying that. Here's one of our last questions today. We still have time for a few more from the audience, so please, if anybody has any additional questions, feel free to type those in now. So Kelly, how do remote pharmacy services work when supplementing on-site resources from a workflow perspective?
Great question. It can work a myriad of ways, and so again, that's why really being very active with the frontline teams up front to determine what the best workflow would be is key. What we've seen that's highly, highly efficient is actually assigning the remote team certain units and say, you take these units, you're responsible, and you own them. From a communication perspective, everything's very, very streamlined. The flip side of that is we've also seen the remote team handle certain order types. And in that case, they're looking through the entire queue, whether it's EPOE or fax or imaging system, and what they do is just literally go through and only pick out the medication order types that they're responsible for. Finally, we've seen where we work hand in hand, the remote team does, with the on-site team, and that can be effective. There just needs to be a lot of communication up front into who owns what, so that everybody knows who's responsible for what, no one accidentally or inadvertently isn't responding to something that they should be. The other piece of it, too, when you're supplementing on-site team, that's key to work out from a process perspective in the beginning, whether you've assigned the remote team certain units or you're working supplementally on the same units, is how clinical interventions are going to be handled and communicated, how communication is going to flow and work between the physicians and the nurses as well. And again, we've seen many different effective ways. The goal is just to make sure that this is identified up front so that you can start out from day one implementation being successful.
Great, thank you. And we have 2 more questions before we wrap up today. What is a safe level of orders to remotely verify CPOE per hour per pharmacist?
That's a very interesting question, and we get that question quite a lot. What we found from a CPOE system is, for one thing, it varies based on the pharmacy information system. And that may sound surprising to some people, but there are definitive varying levels of efficiencies amongst the different pharmacy information systems that are out there. But from a safety perspective, and I can just tell you, at least from ours, and this is actually in conjunction with an ASHP reference that came out about 2 years ago, I believe. It was 32 to 35 orders on average per hour. Now, there's peak times where pharmacists are earning many more than that. And again, a lot of it has to depend upon how the CPOE system is set up and how order sets in particularly are handled. But to be safe and ensure that clinical review, really 35 is a good number to aim for. And again, that's on average, because at any given hour, a pharmacist may do more than that or less than that, depending upon the volume.
Great, thanks, Kelly. And the last question we have here today is, can you please clarify how exactly the patient receives the medications?
That depends upon, that's unique to the facility, right? So in a remote model, we can't really dictate how the patient receives the medications, but this is how, from a flow perspective, it typically works, is that the remote pharmacist is alerted that there's medication orders waiting real time as they're being prescribed by the physicians, whether CPOE or written. The remote pharmacist goes into the hospital-specific pharmacy information system, processes the order, assuming there's no clinical intervention. At that point, if the hospital has automated dispensing cabinets, and most do, not all, then the nurse will be able to go to the automated dispensing cabinet, see that the medication's been approved because there's interfaces that exist between the two, actually physically dispense the medication from the cabinet, and then go to the patient's bedside and actually administer the medication based on the proper instructions. When automated dispensing cabinets do not exist, you still want that prospective clinical pharmacist review. And so we've seen several things, several processes work, because remember, it's still the nurse that's administering the medications based on the instructions that accompany the order. But either the hospital can use, in particularly, we've got an order management system out there, so the nurse can actually go real time and check to see which orders have been approved already, so that the nurse knows they can retrieve those from the med card or wherever they may be stored to administer them. And or the pharmacist can actually fax the nurse a notification if they don't want to use a web-based system to find that out. But the actual physical administration still resides at the hospital level.
Thank you, Kelly. That's all we have time for today. I want to again thank you for your excellent presentation and for all of you in the audience for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.